Hello, everyone. My name is Cristiana Baloescu. I'm a faculty member in emergency medicine at Yale. And today I will be discussing the project entitled Assessing Quantity of B-lines on Point of Care Ultrasound. Is a two-zone protocol enough? Thoracic point of care ultrasound is increasingly being used by many specialties to aid in the evaluation and monitoring of patients with shortness of breath. Thoracic ultrasound uses interrogation of the pleural interface to detect B-lines. B-lines are hyperechoic ring-down artifacts that extend from the pleural line to the far field without tapering and are visible in the slide, in the clip in the slide. In the emergency department, patients present with dyspnea from a variety of pathologies. Detecting B-lines using point-of-care ultrasound can aid in identifying causes of dyspnea. B-lines denote the presence of interstitial fluid, otherwise called alveolar interstitial syndrome on ultrasound. Alveolar interstitial syndrome is found in pathology such as pulmonary edema, congestive heart failure, acute respiratory distress syndrome, COVID-19, pneumonia, and other pathologies. Beyond just detecting B-lines, quantification of B-lines has important implications for illness severity and prognosis for a variety of disease processes. Much of the original research on B-lines and heart failure and many published protocols include 8 or more zones in interrogation of the lung. However, particularly in processes that involve the lungs diffusely, more limited interrogation may provide similar information while being more feasible for routine care. Capturing clips from as many lung areas as possible is thought to increase sensitivity of the ultrasound examination. And while it is often feasible to obtain as many as 28 zones for research, requiring a large number of zones may limit utility and utilization in clinical practice. There's a barrier represented by time as well as effort of scanning many lung zones, particularly in poorly mobile, critically ill patients, and this may discourage physicians from incorporating lung ultrasound in their practice. Few studies have compared the results of different scanning protocols in the diagnosis or quantification of B-lines. We sought to compare a 2-zone anterior superior thoracic ultrasound protocol to a full 8-zone approach. We prospectively enrolled consecutive adult patients presenting with dyspnea or hypoxia, triaged to high acuity areas of an urban academic emergency department. Subjects found to have B-lines on initial lung ultrasound in the anterior superior zones were included. Ultrasound clips of 8 lung zones, right and left, anterior, lateral, and superior inferior, were obtained at enrollment and daily thereafter with a Philips Lumify phased array transducer. A sample of 400 clips representing 50 unique sets of clips for all 8 lung zones from 30 unique patients were randomly selected for this analysis from the larger data set. 2 fellowship-trained experts in point-of-care ultrasound rated severity of each clip. Images on this slide illustrate the 8 lung zones from where ultrasound clips were recorded, with the red circles indicating the anterior superior zones. Ratings of severity averaged over all 8 zones were compared to ratings of severity averaged across the 2 anterior superior zones. These were compared using the Wilcox unmatched pairs signed rank test, as the data did not have a normal distribution. This slide contains clips indicative of each severity rating, from a severity of 0, where no B-lines were visible, to 1 if an occasional B-line was present, but the thought was that the clip was consistent with a clinically normal result. A rating of 2 was given if the clip was abnormal but contained relatively few B-lines, 3 if there was a large burden of B-lines, and 4 at the most severe end of the spectrum. There were 30 subjects with an average age of 72 years, and 47% of the sample was male. 19 out of 30 patients had a primary or secondary diagnosis of heart failure and pulmonary edema, as evidenced in their discharge summaries or discharge diagnoses. 4 clips were judged to have a quality rating of 0 and were excluded from the severity analysis. Across 8 zones, the mean B-line severity was 1.2, and across 2 zones, the mean B-line severity was 1.3. There was no significant difference in scores between average B-line severity ratings from the anterior superior zones bilaterally compared with ratings from the entire 8 zones. This is visually apparent in the box and whiskers plots on the slide, and the p-value for this was 0.6. For the group of 19 subjects discharged with a diagnosis of heart failure or pulmonary edema, there was no difference between the average severity score from 2 zones when compared to the average severity score for all of the 8 zones. For subjects with diagnosis exclusive of heart failure or pulmonary edema, there was also no difference. The p-values being 0.5 and 0.1 for the respective comparisons. Our results suggest that there is little benefit to expanding interrogation of the lungs from 2 zones, meaning the left and right anterior superior zones, to a full 8 zones in terms of evaluation of B-line severity. The study is one of the largest to evaluate the use of a 2 versus 8 zone protocol and included a wide range of pathologies, nearly half of which were not ultimately determined to be congestive heart failure. Our results may not be applicable to specific pathologies with localized B-lines like lobar pneumonia or subtle ARDS where pathology is patchier. In conclusion, a 2-zone approach may be sufficient for quantifying B-lines in a patient population where diffuse B-lines are expected and for tracking B-line severity. Thank you for your attention.